Hey everybody, welcome back to Pulm PEEPs. Thank you for tuning in today.
As you may or may not be aware of, we just passed our 100th episode. We've had over 300,000 listens and downloads in that time. So we're really excited about how Pulm PEEPs has been going, and we appreciate all of your dedication in listening to us. So thank you so much. And we love all the episodes we've done, but we wanted to try out a new feature and new approach today. We're launching forward with Pulm PEEPs 2.0. And so we're going to start with this Pulm PEEPs Pearls series. And this is just going to be Monty and I talking about some things that we've encountered, giving you an overview of a problem, some high yield pearls within that problem in 10 to 15 minutes, a short bite-sized episode. So we hope you guys enjoy it. Certainly send us any feedback or topics that you want to have covered. Monty, this was your idea and I'm super excited about it. So really eager to get going.
Furf, yeah, so excited to be back with you and trying something a little newer. I think more frequent touch points and obviously more touch points with you and discussing cool cases and just things in pulmonary critical care medicine. I don't know what else I could ask for. That would make me more excited. So yeah, really hoping that this works. And what we're trying to do, as Furf said, trying to do more bite-sized teaching, so episodes 15 minutes or less. And today we're going to actually be starting with a common high-stakes ICU diagnosis, Immune Checkpoint Inhibitor Pneumonitis, or ICI Pneumonitis.
Yeah, so this is increasingly something that's been common as cancer therapies have been progressing. The field of pulmonary oncology or ICU oncology is becoming more and more sort of subspecialized knowledge and very common. So you're probably going to see this in the outpatient as a pulmonology clinic. You may also see it in the ICU. And so you probably face the moment when a patient presents who's on an immunotherapy, has an underlying cancer, short of breath, hypoxemic, bilateral infiltrates, and you're trying to figure out what's going on. And I think the broad buckets that we always talk about is this infection because they have a suppressed immune system? Do they have progression of their underlying malignancy and you're seeing some infiltrates related to that? Or could this be an ICI pneumonitis, which is going to have implications on how we treat them, but also on their ongoing cancer therapy. So we have to think about it early and be thoughtful in making the diagnosis.
Exactly, Furf. And just to anchor us with a case, I think all of us have probably seen a patient that we've at least had ICI pneumonitis on a differential. But we'll start with a woman in her 60s with non-small cell lung cancer on pembrolizumab monotherapy or PD-1 inhibitor for the last year, presenting with dyspnea and hypoxia. CT done in the emergency room shows bilateral ground glass opacities. She's admitted to your ICU on high-flow nasal cannula. Furf, what now?
Very common. Certainly have had this type of patient. And for a quick review, when we see somebody who's on pembrolizumab or one of these other therapies, we want to think about what they're doing. So we have a bunch of different medications, PD-1, PD-L1, CTLA-4 inhibitors that all work by taking the brakes off the immune system so that the patient's native immune system can attack and eliminate the cancer cells. But because we're taking the brakes off the immune system, the patient's native immune system can also attack multiple different tissues in their body, including their lungs, and that's where ICI pneumonitis comes in.
100% Furf. And I know so much more pathophysiology to go over, and there's lots of great material on this in an active area of research studying, but we're just thinking about it. The big three mechanisms that you're going to be encountering is really overactive T cells. You can have autoantibody production. And then the third bucket is the cytokine storm-like inflammation. So think elevated IL-1 and elevated IL-6. But as you said, Furf, this is a common presentation that we have. The patient's coming in, high-flow nasal cannula, very sick. We want to act quickly. And one of our first moves that we're going to do is about ruling out infection, right? So this is, and oftentimes you'll start a patient on broad spectrum antibiotics. This can look different at different institutions based on your preferences, but this could be someone that I may want to start cefepime on, as well as azithromycin or doxycycline for some atypical coverage. But as I'm starting that, I want to get a respiratory viral panel, a full one. So not just flu and COVID, but one that will cover a lot of other organisms. Sputum culture if able, already thinking about serum fungal markers. And a patient can tolerate it, you want to think about an early bronchoscopy with BAL. BAL studies in ICU pneumonitis usually show lymphocyte predominant inflammation, but the main thing that you want to do is get a full immunocompromised panel from a BAL if possible.
Absolutely. And I have become much more aggressive about trying to get these BAL in these patients. So even this patient who's on high flow nasal cannula, I've become much more aggressive about trying to do that on high amount of oxygen supports in the ICU. with very close monitoring and after a close discussion with the patient themselves about the risks of it. But it's just so helpful to have had a good lavage culture early on to help you feel more comfortable. It's not infection. And an important thing to remember that within ICI pneumonitis, the CT findings can be very variable. And so you really can not rely on seeing like one signature feature. You could have diffuse ground glass opacities. You could have diffuse alveolar infiltrates like ARDS-like patterns. Some things that look more focal, like an organizing pneumonia. You can have an NSIP type pattern. So you really have to have this early on in your differential, a low index of suspicion to make this diagnosis and put ICI pneumonitis off the differential. So if we have this patient, we get our broad infectious workup, they've been on maybe a little empiric antibiotics, we get a bronchoscopy and BAL, everything's negative, we're certainly going to start thinking about ICI pneumonitis. And the next stage in our care for ICI pneumonitis is to think about the severity of this and how that's going to guide our treatment. This grading scale of severity really came from the initial trials in ICI therapy. And so we've been using it going forward to guide our clinical management. The most important pearl to take from this is that the severity is based on the patient's symptoms and oxygen needs, not by the imaging. So certainly we're more concerned if somebody has diffuse ground glass opacities in all lobes, but we really have to go based on how the patient is feeling and what oxygen support they need. So grade 1, asymptomatic, we're going to monitor this patient closely. We may hold the ICI. I have this in clinic sometimes. Somebody has a surveillance CT. They have some infiltrates, but they're actually doing really well. We may just delay the ICI things, see if things are clear. Grade 2, we have symptomatic but not hypoxic. These may or may not be in the hospital. We're going to start steroids for this patient at prednisone 1 mg per kg per day and start seeing if they get clear. We may or may not be able to continue their ICI later on if things get better. For grade 3 or 4, these are hypoxemic or ICU level of care patients. They are going to get IV methylprednisolone 1 to 2 mg per kg per day right away up front. And we're going to hold or permanently stop that ICI because this has been a pretty severe reaction. So Monty, I know this comes up. People are often talking about, what about if we do much higher dose steroids? How long are we going to do the steroids? So what's been your approach to this?
Yeah, such a great question. And again, probably some institutional variation. But there's not great evidence to support doing a pulse or 3 days of 0.5 gram or 1 gram of methylpred and then going to the 1 to 2 mg per kg per day taper. I've definitely done that though. And this is something that I'm obviously talking with our ICU team about and talking with the oncology team as well. So that can be done, but I will say that there's not a lot of evidence to support it. But for you mentioned some great things. One, imaging does not dictate what grade the patient's presenting. It's really with patient's symptoms and whether or not we're temporarily holding or permanently stopping an ICI. So for the purposes of this episode today, really going to be focusing on the grade 3 of 4, where we're thinking and talking with our oncology colleagues, permanently stopping ICI therapy. But as you said, for management, steroids, first line. So for grade 3 or higher, want to start methylprednisolone 1 to 2 mg per kg per day, and then start thinking about tapering over 6 weeks. And I know sometimes in the ICU, we're going to start this, the patient, we're going to have to see how they respond. But I like to at least have trainees think about what a potential taper could look like. So what our usual taper is, week 1, we're going to start 1 to 2 mg per kg per day. Week 2, I'll decrease that and do 0.75 mg per kg per day. Week 3 and 4, I'll do 0.5 mg per kg per day. And you can see this decreasing over time. Week 5 is going to be 0.25 mg per kg per day. And then week 6 will be 1.25 mg per kg per day. And then we'll plan to stop. I think an important thing is that for some patients, you can have more of a chronic ICI pneumonitis, and that's obviously going to need close follow-up and multidisciplinary care. But if you're seeing someone in the outpatient setting, you may have to say, they may be like, wow, once I got to prednisone 20, I felt great, but once I stopped it, my symptoms seemed to flare and I seemed to take lots of steps back. Then that may be a patient where I say, what dose were you last doing? On 20 milligrams, great, let's go ahead and restart that. Have you follow up closely in care, but we'll do a slow taper, and this could be even a taper over months. A lot of individual discussions with patients, monitoring symptoms very closely in the outpatient setting once you get to these tapering therapies. But Furf, the next question, what if steroids don't work?
This is always the thing that comes up. It comes up, sometimes people come up about being really aggressive up front, but more often you're on steroids for a day or two, they're still on high flow, or they're maybe a little better, but really not resolving. So after 48 to 72 hours, it's time to think about escalating. There's going to be a lot of institutional variation here about what you go to next or how quickly you put this on. But the broad options that we have are really adding IVIG, so intravenous immunoglobulin. This is a total of 2 grams per kg. It's usually spread out over 5 days that we start to administer in addition to our steroid therapy. If we're not doing that, or sometimes in combination, again, depending on your institutional practice pattern, we might think about adding infliximab. This is a TNF alpha inhibitor to dampen down that immune response. We do want to make sure we screen for tuberculosis and hepatitis before we start this medication. So if you have an ICI pneumonitis patient coming in or someone you might suspect it, go ahead and start and send those off right away so that if you come to this decision point, it's not a holdup for you. And then finally, we can add MMF or mycophenolate mofetil. We really want to get to 1 to 1.5 grams per day right away, split between BID or TID dosing. And this is just a little bit different than when we use this medication in the outpatient setting for ILD patients, where we really start and move up slowly, monitoring LFT slowly, monitoring for side effects. We really need to get to an effective dose very quickly for these patients. Monty, I'm curious what you've seen and what you think the data shows about choosing between these therapies.
Yeah, thanks, Furf. And great question, right? There haven't been head-to-head studies comparing the 3 of these agents together. But IVIG has been associated with lower mortality in some series. Each of these medications has its own risk factors. I will say what I tend to do in institutional preference is we pull for IVIG pretty soon and pretty upfront if our patient is not getting better. But right, IVIG has its own potential complications. Volume overload, prothrombotic. Patients can have an adverse reaction to the IVIG itself. So obviously monitoring in a very close setting. But these are just discussions and decisions that you have to make sure that you have with the patient, the family, as well as your colleagues and consultants.
Yeah, absolutely. So that's a great review of where we are in diagnosis and treating ICI pneumonitis. There are some things in the ether that are going to be coming up soon. So JAK inhibitors are emerging as a possible treatment for this. They could have a role here. We're still a little bit early in that story, but maybe we'll do another Pulm PEEPs Pearls and keep you posted if there's some new data to cover with that.
Exactly, Furf, right? Definitely a space to watch. I think such an area of active research that's going on. But for today, we'll end with our Pulm PEEP Pearls. ICI pneumonitis is a diagnosis of exclusion. As we talked about today, ruling out infection first. Any new respiratory symptom in a patient on immunotherapy or who has been on immunotherapy in the past warrants an evaluation. CT chest and, if possible, BAL from bronchoscopy are key tools. And again, just remembering the pattern of that you're going to be seeing on CT images can be varied, and it's not the radiographic pattern that deciphers the grade, as Furf talked about. We talked about starting steroids early for grade 3 and 4 pneumonitis and potentially stopping the agent indefinitely with a gradual taper. And don't forget, as you're doing this, to make sure that they're on GI prophylaxis as well as PJP prophylaxis. And then, as always, caring for patients in the ICU. Critical care is a team sport, and involving multidisciplinary consultants is essential.
Thank you, Monty, for summarizing it all. Thank you all for listening to our first Pulm PEEPs Pearls. We'll like to try to refer you to some papers or reading for this. You can always go to our website. But the one I'll do for this, I'm excited to announce Christina published earlier this year in Chest Critical Care about how to manage immune checkpoint inhibitor pneumonitis. So if you want a more detailed discussion, I would suggest you check out that publication. This episode was written, edited, and produced by myself and Christina Montemayor. The music's original music by Eric Rogers. And we'll see you next time.